Dr. Krishnendu Nandi. He will be speaking on ICG angiography.
Yeah. Good morning, everybody. So my presentation is little old presentation of ICG is rarely practiced nowadays. So why we do need ICG? Because of these things, because this case, first one case is a block fluorescence because of the blood, and doing ICG will reveal the polyp. Again, the second case showing the hot spot in ICG. So this patient has to be treated. So we have to diagnose the cause. The first ICG was used in measuring cardiac output 1957, but in its digital practice in 1992 in ophthalmology. So properties is, everyone knows the most important thing is a high plasma protein bound, about 98%, which has its work in infrared region, and that is most useful for us. Limitation, the limitation of FFA, which we cannot study the choroidal circulation by FFA, that can be done by ICG. Advantage of the ICG, we can see the lesion which is being obscured by the ocular pigment and hemorrhages, relatively safe dye, and doesn't have very high side effect. Adverse effects, nausea, vomiting is all cases, and severe anaphylactic shock often lessly encountered. So angiography, there's an early phase of angiography. Early mid phase, there is 1 to 3 minutes. Late mid phase, this is the most important phase, 3 to 15 minutes time. And late phase, 15 to 30 minutes. So very important terms we should know: the hot spot. Hot spot is an area of abnormal intense fluorescence in the mid and late phase of ICG, but size should be less than 1 Dix diameter. And plaque, the size is more than 1 Dix diameter. The polyp, this lesion demonstrates intense focal or multifocal spots within 6 minutes of ICG angiography, but this has to be treated. RAP, the difference is the same, is a single hotspot, not multiple, and the timing is same mid and late phase of ICG. The indication of ICG, mainly the occult neovascularization, IPCB mostly, RAP lesion, and CSCR often present with CNVM. Inflammatory conditions, some choroidal inflammatory condition, some cases of choroidal hemangioma, and ICG enhanced laser photocoagulation is an indication. This is a case one where the patient, if it doesn't show anything, the ICG shows hotspot, so we have to treat nowadays with injection, previously with PDT. The case, second case, this is a case of block fluorescence, lot of block fluorescence in FFA, but ICG, this is a camera-based ICG, shows there is a 2 hotspot at the supratemporal quadrant, which is actually treated with a focal laser. And after 6 months, again the patient presented with the leakage somewhere else, detected in ICG. This is a peripheral leak. Again, we can do the focal laser, but in addition with the injection because of the subretinal fluid, and patient received 2 injections subsequently. The most interesting thing is the peripheral PCB. You can see the peripheral polyp in the supratemporal quadrant of the same patient. And we can treat this thing with a laser and pneumatic displacement with injection. It's a case of RAP lesion. You can see the retinal choroidal anastomosis, and this usually treated with PDT. There's a case of CSCR, 636 vision. Why we do FFA? Because to see the central leak. Previously, we has to be treated. If it is a chronic for more than 6 months, then we can treat with the PDT. Nowadays, we often observe. And after resolution, after doing PDT, the vision improved to 6.9. The RAM lesion, often we cannot see the leakage actually. The ICG will point out the leakage in RAM lesion. There's a case of choroidal hemangioma. Before the dye appears in the circulation, we can see the tumor lesion quite easily. And after PDT, everything resolved. Choroidal inflammation also a great role to play. Mostly the choroidal inflammatory mediators, often it shows the extensiveness of the disease. Often we can be missed by clinical examination and FFA. More extensive the disease, more poor the prognosis. Even with the steroid therapy, the multiple hypofluorescent spot which can be seen in ICG is reduced with time. So these are the example of AMPP where a lot of hypofluorescent lesions are seen in ICG. Punctate inner choroidal lesion, again the same, the hypofluorescent lesion in the ICG. Azure, again the same, we can detect the azure lesion in ICG. Now, therapeutic uses of ICG, mostly the PDT, in the era of PDT, there is an essential need of ICG. Nowadays, it is hardly in practice. See, this is the area of polyp. The whole area has to be done with a PDT lesion and everything is gone. The role of video ICG to demonstrate the dynamic presence of polyp. Here you can see there's a polyp lesion here and with a branching vascular network. So advantage of ICG, we can detect polyp more easily than the OCTA, though it is invasive. But nowadays, it's hardly in practice because of non-availability of PDT in many centers. So in conclusion, ICG is still useful in some cases where the FFA doesn't give any role or OCTA fails to give us any polypoidal lesion, and also in cases of CSCR presented with CNVM. Thank you for your patience hearing.
Thank you for being on time. Dr. Judge.
Yeah, thank you, Dr. Krishnendu. And, you spoke about ICG in PCV versus RAP, actually. Beautifully pointed. The point to highlight here is both have nodular hyperfluorescence or hypercyanescence, but the timing, early versus late, is one of the important differentiating features where you have the early in one and the late nodular in RAP lesion, other than the retinochoroidal anastomosis that we see in RAP lesions. And I would disagree that RAP PDT is no more a choice of treatment, because it will affect, if there is a retinochoroidal anastomosis, it can injure the retina if there is a retinochoroidal anastomosis. So PDT is no more an option in RAP lesions. And to extend to what Dr. Vishal had highlighted on ultra wide field, he had shown, but now we have ultra wide field. Beautifully he showed the fundus photographs, but then now we have the ultra wide field FFA and ICG as well. So I would just like to highlight that in fluorescein angiography, 3 indications where the ultra wide field FFA would be particularly useful is the peripheral vascular lesions in diabetic retinopathy, in 10% of the diabetic retinopathy on ultra wide field, and in RVOs as common as 40% in the peripheral vascular, which you don't pick up with the normal up till equator fluorescein angiography, and peripheral vasculitis in fluorescein angiography. ICG, ultra wide field, especially in peripheral exudative hemorrhagic variant of the PCV. So, and even in CSC now, the ultra wide field ICG is very important.
Yeah, thank you. I think that's what